Hello everyone, I am Dr. Nalini Bansal and today we will discuss the next topic of gastropathology course, and that is EUS Cytology. Now, EUS cytology is a very important topic in the GI pathology because this is a specialized type of FNAs that we get in cases of especially related to the gastrointestinal lesions. So now there are certain prerequisites before we enter into the endoscopy room, and what all preparations should be done before we are ready for doing an on-site EUS FNA. So for what are these prerequisites are? First, we should be aware of what is in EUS, what are the different areas that are sampled in EUS, what are the contaminants that we will see in EUS, how to stain the slide, and finally comes the competency of the pathologist who is seeing this EUS. So first and the foremost question is, what is an EUS? So EUS is an endoscopy plus it's an ultrasound. So basically what they are doing is they are putting an endoscope into the gastrointestinal tract, and this endoscope is being used to for the direct visualization of the GI mucosa. It has got a camera that is attached to the end of the endoscope, and with the help of this camera they can directly visualize any lesion that occurs in the GI mucosa. So if there are any ulceration, any polyp, any defect, any areas of bleeding, that can be visualized directly with the help of this endoscope. Now what is happening in EUS is they are combining an endoscope with an ultrasonography probe. So basically the gastroenterologist here is performing the duty of a gastroenterologist as well as that of a radiologist. So what he is doing is, in addition to visualizing the mucosa of the GI tract directly with the help of the endoscope, he is also utilizing an ultrasonographic probe at the end of this endoscope. So it has got dual role, a camera is attached here, and in addition we also have an ultrasonographic probe. Now with the help of this probe, it can pass some sonographic waves, and then these waves can cross the GI lumen, and it can also help to visualize the areas that are outside the GI tract but in the vicinity of the gastrointestinal tract. So endoscopic ultrasound is used to visualize the gastrointestinal mucosa as well as the structures which are present adjacent to the GI tract, and of these the most important structure is the pancreas, that is the pancreatic lesions. Now we have discussed about the endoscope, that an endoscope has a camera. There are different kinds of probes that can be used for visualization of the structures which are adjacent to GI tract, and one of them is the radial probe, but this is now not much used these days, and the commonly used probes are the linear arrays or the linear probe that we see for the Olympus needle also, and these linear probes, they help to visualize the structures adjacent outside the GI mucosa. So this is the ultrasonographic probe that is present at the end of the endoscope. Then there is a camera that is present at the side of the endoscope, and there is also a slot through which the needle can come out if you want to take an FNA from the structures next to the GI tract. So next is, what all areas can be sampled with the help of an EUS. So with the help of an endoscopic ultrasound, you can sample all the lymph nodes that are seen adjacent to the GI tract. You can sample, in addition to the lymph nodes, the structures which are next to the GI tract, and of these the most important, as I said earlier also, is the pancreas. So there are different stations of EUS. So with the help, when they are putting an endoscope, at times they are going to say that we are resting on the station 1, we are resting on station 4. So you should be aware of what are the different stations of endoscopic ultrasound, so that if the clinician is using the terminology as a station, you are aware that he is resting on this particular area of the endoscopic ultrasound. Like the station 7 is for the subcarinal lymph node. Then we have station 8 and 9, which could be sampled only with the help of an endoscopic ultrasound. So now we also know that there is an endobronchial ultrasound that is used for sampling the lymph nodes which are adjacent to the bronchi. So many areas can be sampled with the help of an EBUS as well as with the help of an endoscopic ultrasound. So there is an overlap. So gastroenterologist can also sample some subcarinal lymph nodes, and similarly a bronchoscopist can also sample some of the pericarinal or parabronchial lymph nodes. So these areas can be sampled by both of them, but there are certain lesions which can be sampled only with the help of EUS and not by the help of EBUS. Similarly, there are certain internal nodes that can be sampled only with the help of EBUS and not by the endoscopic ultrasound. So both have their own importance when pertaining to the areas that can be sampled. Now these are the different stations when they will take samples from the endoscopic ultrasound. So station 1 is the sternal notch node, then sternal notch nodes, then we have upper paratracheal nodes, prevascular and retrotracheal lymph nodes, lower. So these are the different stations of the lymph node, and the commonly sampled is the subcarinal or the station 7 lymph node. So these are the different lymph nodes that are present at different stations. Then in addition to these lymph nodes which could be sampled within EUS, they could also sample the areas, like they could sample any mets in the liver, because the endoscope is passing through the GI tract and this liver is adjacent to the transduodenal route. So with the help of a transduodenal or transgastric route, they can enter the liver mets. They can also sample lesions from the adrenal and also from the pancreas. Now this green one represents the area that could be sampled both with EBUS and EUS. So these green ones we can take the FNAs with the help of an EBUS as well as with the help of an EUS. But the yellow ones, that is these para-aortic lymph nodes, liver mets, adrenal lesion, pancreatic lesions, they could be sampled only with the help of an endoscopic ultrasound. So this we should be aware of when we are going for an on-site evaluation of an endoscopic ultrasound guided FNA. Now, as I said previously also, so this is an endoscope, and at the top of the endoscope we have the probe through which we can visualize the lesion. So with the when they will open the endoscope, when they open the ultrasonographic probe, they could visualize that yes, if this is a pancreas, there is a lesion in the pancreas, and once they have identified the lesion in the pancreas with the help of ultrasound, and then they can pull out the needle and they can start to sample the pancreatic lesion. So this is an ultrasonographic representation of the same, showing that the lesion in the pancreas is sampled with the help of the needle. So the utility of this endoscopic ultrasound FNA is that you can sample any lesions in the pancreas with the help of the gastrointestinal route. And the importance of doing this with the help of GI tract is that there is no seedling of the tumor cells elsewhere in the GIT, which will occur if you do it a CT guided FNA, which are not so commonly used for taking a pancreatic FNA. Now this endoscope can be used to sample the lesions of the pancreas or adjacent structure, and as you can see here the needle is passing through the stomach route. So this is a transgastric route through which the needle is passing. But if suppose the endoscope has come over here and the lesion is more better visualized from the duodenum, then they are going to do a transduodenal route wherein the needle will be passed through the duodenal mucosa. So depending upon the localization of the tumor or the localization of the lesion, they can prefer to do either a transgastric FNA or a transduodenal FNA. So now coming on to the role of a pathologist on the EUS evaluation. So this is called as rapid on-site evaluation or ROSE, in which the pathologist goes into the endoscopy room and then on-site he is going to tell whether the samples are adequate and if possible what is the likely diagnosis. So ROSE is rapid on-site evaluation, which is done with the help of pathologist and gastroenterologist. It is utilized when the gastroenterologist is very aggressive and he really wants a diagnosis out there in the endoscopy room. Those who require quality reports, especially because if you tell them that there is a granuloma lying there, then they can also modify the reports accordingly. So it increases the quality content of the endoscopy report that the gastroenterologist is going to give to the patient. It improves the efficacy and reduces the number of inadequates. So suppose if the clinician has visualized a lesion in the pancreas and he has taken out a sample in which you do not see anything that is representative of the lesion, so therein you can tell that the sample is inadequate and we need some more passes, so before saying that this is inconclusive. So it reduces the inadequate samples which are performed through this endoscopic procedure. Now the important point here is the time of the pathologist, as it is a very demanding procedure and sometimes it can go even up to an hour, and if in a very busy lab it will be difficult to do an on-site evaluation because it's relatively demanding. So time of the pathologist is also very important. Now rapid on-site evaluation definitely, as I said, is going to reduce the inadequate samples because you can always ask for more passes. But these are an important learning areas in a setup that is starting. So in these learning areas you get to know how are the different lesions they look like on an ultrasound, what is the vascularity and what is the nature of vascularity for different lesions, how does a necrosis is going to look like on the Doppler studies, and this will help you to evaluate these FNAs on site. So on site evaluation is really important both for the pathologist as well as for the gastroenterologist from the learning point of view. Now, if you are going for an on-site evaluation, there are few things that you require to be set up before you go for an on-site evaluation, and that is the EUS cytology setup. You need a microscope. You would require a stain that can quickly stain the smears, and the commonly used stain is the diff stain. And in the diff stain, what you do is immediately when they are going to put the material on the slides, you are going to air dry the slides, and these slides have to be air dried thoroughly, because if they're not dried up properly and you put them in the fixative, that is methanol, the material that is present on the slide will be washed off. So you should do a thorough drying of the slide, and that can be done with the help of an air dryer that you can also put in the endoscopy room. So you can utilize an air dryer. You put the slide under the dryer and then it will dry immediately. You put the dried slide in methanol, give it some 4-5 dips in the methanol, take it out, put it in eosin, that is dips B solution, that is the eosin, give 4-5 dips in eosin, wash in distilled water, and then give some more dips in the hematoxylin. So dip B, dip A, that is how you are going to do. Wash in distilled water, mount, and then you can see in the microscope. So that is what you are going to do for the on-site evaluation. So it's a fast procedure. You can do it within 5 minutes and then you can visualize the smears. And once you know that what the pathology, once you know that the smears are adequate, you are getting the samples from the lesion, then depending upon what the lesion is, you can also tell them that whether a cell block will be required for this particular case or not. So what is a cell block and how it is prepared in an EUS guided FNA? So now they have taken out the material from the lesion, and this material they have drawn some slides, and suppose if you feel that this lesion will require immunostains for further categorization, then you can ask them to take some more passes, and they can put those passes into a container in which you can later on utilize for making a cell block. So this material for making a cell block, there are different ways by which you can make cell block, and the commonest used method is the formalin method, in which you add 10% of the formalin to the sample that you have obtained through the EUS for 4 to 6 hours, and then next day you can process it routinely as your usual sections. So whatever material that you have collected with the help of this EUS FNA, you are going to centrifuge it at 1500 rpm for 10 minutes. You discard the supernatant and the residual pellet that you will get. To this pellet you add 10% formalin, keep it for 4 to 5 hours or overnight, and the next day you can process it in your routine samples. So that is how you are going to make a cell block. This is one of the way to make a cell block in a resource constrained setting. There are different other methods also by which you can make a cell block, and a beautiful paper on it is by Dr. Dipali Jain, who has done a thorough study on the cell block preparation. You can go through it on the net also. Otherwise, the different methods that are commonly utilized is one which is discussed by a senior technician, that is the Nathan's technique, in which he is utilizing 90% alcohol, 99 parts of 100% alcohol and 1 part of 40% formalin. So 9:1 ratio, 100% alcohol and 40% formalin. So that can also be utilized as a fixative instead of just 10% formalin. So 9:1 is one fixative. Some people are also using 7:1 ratio, that is alcohol to formalin ratio. And there is another technique, that is the thrombosol method, in which to the material that you have collected you add thrombosol, that is called thrombin method, and it is specifically used when you have gotten hemorrhagic fluid if you want to lyse the RBCs. So these are certain different methods that can be used for making cell block, but the commonly used method is you just put 10% formalin and then you process it as a routine sample. Now this tissue block that you will get after cell block preparation, it can be utilized for doing any amount of immunostains if the material is there on the cell block. Now once you have drawn the smears, you have told them that yes, the slides are adequate, then you should be aware of what are the normal luminal contaminants when you are going for EUS FNA. So what are the normal contaminants that you see? So this will depend upon what route they are taking for taking out the sample from the lesional tissue. So if they are taking a transesophageal route, so if the needle is passing through the esophagus, you will land up seeing some of the squamous cell in the lymph node sample. So this is like from a subcarinal lymph node, and you are seeing many squamous cells over here. And you should be able to know that this is through because this is through the transesophageal route, and this is not actually some squamous cell carcinoma or any other atypical squamous lesion, because most of these squamous cells are going to be mature squamous cells, and there is no hyperchromasia or any abnormal squamoid structures over there. So this is a common contaminant when the sample is taken through the transesophageal route. Now, if the needle is passing through the stomach, so if the needle is passing through the gastric mucosa, then you will end up seeing many foveolar cells. So these are the surface foveolar cells, and we know that most of these foveolar cells will have an apical mucin cap. And if you look carefully, many of these cells, like this cell, is having a apical mucin cap. So they will be seen as numerous holes within this foveolar sheets, and this is the some foveolar cells that are going to look like on the cytology. So if the needle is if passing through the foveolar cells and you are getting many foveolar cells, you will see these as a gastric contaminants. Now on the MGG stains, the foveolar cells are going to look like this, in which these are the foveolar cells. And if you look here, like this cell, it is also having a apical mucinous apical mucin cap. So this is the normal basal nuclei, and here we are having a mucin cap, and these are the normal gastric foveolar cells which are present. Again, another stain which is showing you the presence of normal gastric foveolar cells. Now, sometimes if the needle is passing through the gastric glands, and this is the gastric gland that we see on HE. Now, we know the gastric glands are made up of parietal cells and chief cells. So, the parietal cells are going to be eosinophilic and chief cells are basophilic. And this is how they are going to look like on the cytology. So, on the cytology, they are much more apparent as we see them on the histology. So, these eosinophilic cells with abundant eosinophilic cytoplasm, these are the parietal cells. And here we have the abundant granular basophilic cytoplasm, and these are the chief cells. So this can also come as a contaminant if they are passing through the gastric glands and they are sampled on the cytology. Now, if the needle is passing through the duodenum and you are getting a sample through the transduodenal route, then at times you are going to see the surface columnar cells with the presence of goblet cells. And this is a normal contaminant of the duodenal mucosa, in which you see monolayered sheets of columnar cells, and in between there are many holes which actually represent the presence of goblet cells within the sheets. So now if the needle, suppose there is a lesion in the pancreas, and through the duodenal route they have now entered into the pancreas, but they have not actually hit the lesion, and the needle is just going into the normal pancreas. So this is the normal pancreas where you see numerous acini that are being present, and these acini on cytology they are going to look like this. So many of these acini will be rounded balls. They are small structures. They are not too many in number. You will see occasional acini, and the cells are going to be uniform. They are similar to each other. There is no prominent nucleoli that is seen in the normal acini, and that is an important finding that will help you to differentiate normal acini from an acinic cell carcinoma. In an acinic cell carcinoma, the cells are going to be hyperchromatic, though they will still retain this acinar structure. They are going to be much more numerous, so there will be sheets of these cells, and then you do see presence of prominent nucleoli within the acini. So that is acinic cell carcinoma. Otherwise, the normal pancreatic acini will be occasional, and they will be similar appearing without the nucleoli. Now, if they are hitting the normal pancreatic duct, as we know that the duct is lined by columnar epithelium, so in those cases the duct is going to appear as the monolayered sheets, and this is the monolayered sheet that we are going to get on the ductal epithelium, and this is the normal pancreatic duct that is sampled. Now, once we know that these are the normal luminal contaminants and we are for an on-site FNA, so by seeing the normal luminal contaminants, we are not going to say that this is an adequate sample. So we are going to ignore the luminal contaminants, and then we are going to move forward to the pathologies. As I said, the lymph node pathologies, all of us are aware of what are the different pathologies that can come in the lymph node. So in this session, we'll be focusing mainly on the pancreatic pathology and what are the different lesions of the pancreas that could be sampled with the help of EUS. Now, in the pancreatic lesions, they could be non-neoplastic or neoplastic. In the non-neoplastic ones, the pancreatic pseudocyst, especially in the setting of chronic pancreatitis, is an important thing to be sampled. Then in the neoplastic cyst, we have cyst which shows mucin and cyst which will not show mucin. Which will show mucin are the mucinous cystic neoplasm, and in this we have IPMNs, that is intraductal papillary mucinous neoplasm. We have mucinous cystic neoplasm. Both of these will show mucin on cytology, but IPMNs are within a duct, whereas mucinous cystic neoplasm has nothing to do with the duct. It lies separately. There is no connection with the ductal system. Now, if there is no mucin and we are just getting fluid from the sample, so that fluid could be serous cystic neoplasm, it could be SPEN, which is unique to pancreas. Then we could see multiple neuroendocrine tumors and sometimes acinic cell carcinomas. And finally, the commonest lesion for which an FNA is taken from pancreas is the pancreatic head mass, and that is because of a ductal adenocarcinoma. Now, this is as I said, this is the commonest pathology for which a pancreatic FNAs are taken, and this is a ductal adenocarcinoma. There is a mass in the HOP, that is head of the pancreas, and because of this mass, there is obstruction of the common duct, and there is upstream dilatation of the common bile duct as well as the pancreatic duct. So because of this dilatation of common bile duct and pancreatic duct, it is going to appear on MRCP like this, and this is called as on the ERCP like this, and this is called double duct sign. So this double duct sign is very specific for pancreatic carcinomas, and in the double duct sign, if the caliber of the duct, if the ductal caliber is more than 5 mm, that indicates that the duct is dilated, and if it is more than 10 mm, that is 1 centimeter, then it definitely indicates that there is a definite ductal dilatation, and it is a very sensitive sign to know that the mass that we are seeing in the pancreas is actually a malignant tumor. So once we have seen the different things that could be diagnosed in the pancreas, what are the different diagnostic categories that are used for saying that the different lesions in the pancreas? So the diagnostic categories could be: 1, that is non-diagnostic; 2 is negative; 3 is atypical; 4 is neoplastic; 5 is suspicious, and 6 is positive or malignant. Now we know that there is little confusion when we are looking at the category 3 and category 5, and also category 4 and category 6. So they look almost similar, but there are differences, and that we will see subsequently. Now this positive or malignant means we are dealing with some adenocarcinoma that is definitely malignant. So we are basically talking of ductal adenocarcinoma here, whereas in neoplastic we are talking of some neuroendocrine tumors, spens. We are also talking of cystic lesions of the pancreas, and in atypical and suspicious, that we will see subsequently. So in the neoplastic, we could have benign lesions which could be serous cystadenomas, and this is the category 4, and in the category 4 we could also have IPMNs, MCNs with low or high grade dysplasias, and then we have SPEN, that is pseudopapillary tumor, and pancreatic neuroendocrine. So since it is little confusing, so we are going to share this on a case based scenario, and this is a made up scenario, and we will see if we are going to get samples from this lesion which are different in morphology, how we are going to interpret it. So let's see a scenario 1, a 62-year-old male presenting with jaundice. So old male with jaundice, and on EUS there is a mass in the head of the pancreas which is measuring 35 into 20 millimeter. So an old male, mass in the head of pancreas which is 3 into 2 centimeters, a large mass in the head of the pancreas in an older male. So at the time when we are going for an FNA, on-site FNA, the first thing that is coming to our mind is we want to rule out whether it is a ductal adenocarcinoma or not. Now suppose from this FNA we get a sample like this. Now in this sample we do not have any epithelial cell. There are some debris, some dirty material over here which is actually non-diagnostic. So with this we could not explain the mass in the head of the pancreas, and this we are going to say that this is inadequate. So this is the category 1, and for this we are going to ask for more passes. Now from the same smear, suppose if we get a sample like this. So from the same lesion, if we are getting multiple plasma cells, occasional lymphoid cells also, inflammatory smear full of inflammatory cells, so this inflammation can explain the mass in the head of the pancreas. And since we are seeing a predominance of the plasma cells, so we are now thinking on the lines of autoimmune pancreatitis also. So for this case we would like to get a cell block to do IgG and IgG4, and if possible they can do an EUS-guided biopsy also, which is done, that is called EUS biopsy. But since they are very thin core, so they are generally fragmented, and the pores are generally very thin, so it is difficult to interpret them. But otherwise on this smear we know that it is not non-diagnostic, and the pathology that we are seeing could explain the mass in the head of the pancreas. So this is category 2, in which it is non-neoplastic, it is diagnostic, it's an inflammatory lesion which could be autoimmune pancreatitis, and you would like to do further details, that is IgG, IgG4, and you would like to know the serum IgG4 levels of the patient. Now suppose from the same lesion we get a cell cluster like this, in which there is some columnar epithelium, there is little atypia, and suppose in this background also we are getting many polymorphs, many inflammatory cells. So since the lesion is not looking that atypical to be called as equivalent to a malignancy, and it is not looking as a normal luminal contaminant also, so this is what we are going to call as atypia, in which you are not able to categorize it further, and at times this atypia could occur secondary to a regenerative or a reparative phenomena also. So this is your category 3, in which you are going to call it as atypical. Now suppose from the same lesion in the mass in the head of the pancreas you are getting a sample like this. So for this again you could see that this could represent the lesional tissue that is present in the mass HOP. Most of these cells are similar looking, so they've got a uniform monotonous appearance to them. They've got ill-defined cytoplasm, there is no definite cytoplasmic boundary, and the nuclei are looking finely vesicular. So this monotonous appearance is usually seen in a neuroendocrine tumor, and in a if you are thinking of a neuroendocrine tumor, again you would like to take a cell block to do your immunostain. So this is again category 4, in which it is not malignant but it is some specific type of pancreatic lesion which is a neuroendocrine tumor. So this is a category 4 lesion. Now suppose from the same mass in the head of the pancreas, this is a single cluster that comes on the slide. It looks relatively largely atypical, and there is a large cell over there, but you are not able to call it definitely as malignant because the cellularity is very low, and that is preventing you from calling it as a definite malignancy, but in the back of your mind you are still thinking that it could be malignant. So this is category 5 lesion in which it is suspicious for malignancy, but you are not calling it as definitely malignant. Now suppose from the same lesion we get multiple clusters like this. So in the same lesion, if in this smear we have got multiple clusters which are showing you hyperchromasia, irregular membranes, there is irregular nuclear membranes also, there is overlapping, and there are many clusters like this on the smear. So we have no problem in calling it as malignant. It is not looking like a neuroendocrine tumor, there are no neuroendocrine features, and it is definitely looking malignant. So we are going to call it as a category 6 lesion, that is malignancy, and it is an adenocarcinoma. So that was about the different categories that we will see for the pancreatic lesion. Now moving on to scenario 2, in which we will be discussing about the cystic lesions of the pancreas. The cystic lesions of the pancreas could be serous cystic neoplasm, as we had discussed. It could be mucinous cystic neoplasm. It could be intraductal papillary mucinous neoplasms, or it could be pseudocyst of the pancreas. Now we know the word pseudo will come from because it has no lining epithelium. It has come as a result of degeneration of the normal pancreatic acini as a result of high amylase level, and this is called pseudocyst with the debris. The mucinous cystic and SCN, that is serous cystic neoplasm, both of them, they do not have any communication with the duct, whereas the IPMNs, they are seen within the duct, and it could involve either the main duct or the side branches of the duct. So IPMNs are intraductal papillary mucinous neoplasm. So there will be papillae, there will be intraductal mucin, and most of these will show you ductal dilatation, whereas the mucinous neoplasm will have no connection with the duct, and the duct will be of normal caliber. Now, if you look at the age group of these lesions, so this is an important pictograph which is showing you that the solid pseudopapillary lesions, they are common in the younger age group. So young child daughter, it will present a solid pseudopapillary lesion. The mucinous cystic will present in the middle age, that is around the 40s, and the serous cystic neoplasm, they are going to present in the later age group, that is around cystic. So grandma cyst is actually serous cystic, mother cyst is mucinous, and solid pseudopapillary, they are usually seen in the younger age group, less than 40 years of age. So this is a general categorization of the cyst, though this is not definitely absolute, but this is the usual presentation. Now, at the time when you are looking at the fluid morphology, it is also important to look at the fluid biochemistry, because this will give you important clues even if the serous fluid, the morphology of the fluid is not absolutely mucinous or not. So if you are getting a very high CEA levels, so carcinoembryonic antigen, if they are very high, that would indicate that the cyst that you are dealing with is actually a mucinous neoplasm and it is not a non-mucinous lesion, because mucin will cause increase in carcinoembryonic antigen. Now, if you are dealing with an atypical IPMN, the amylase are going to be very high in addition to CEA, and amylase is also high in pseudocyst because it is resulting from the degeneration of the acini, but the CEA is going to be low in pseudocyst. So these are important biochemistries that will tell you what type of cyst you are dealing with. In the serous cystic neoplasm, amylase and CEA both are going to be low. Now with this we move to scenario number 2, in which we will be discussing a 35-year-old female, and we will discuss this is again a made up scenario in which we will discuss the morphology of different types of cysts and how we are going to categorize them further. So 35-year-old female, pain upper abdomen in the left flank for 1.5 months, and this is the pancreatic cyst aspirate. So first and the foremost thing is, what is the morphology of the cystic aspirate? So this is gross of the cyst aspirate is very important. So if the cyst is looking dirty, then you are thinking of a pseudocyst. If it is hemorrhagic, you are thinking of serous lesions, or you are also thinking of neuroendocrine or pseudopapillary lesions. If it is thick mucinous, you are definitely thinking of mucinous lesion, and if it is straw colored, again you are thinking of a serous or a mucinous lesion. So all mucinous cyst will not definitely show you the presence of mucin. At times the cystic aspirate could be straw colored also. So this is an important gross morphology that should be known. Now suppose from the cystic lesion that we have described, we are getting a morphology like this. Now in this morphology, what we are looking at, there are hardly any epithelial cells here. There are numerous debris, there are occasional foam cells which are present, and there is abundant dirty necrotic debris in the background. No definite epithelial cells, some clustering is there, but these are all the normal epithelial cells. So there is no absolutely epithelial cells here, numerous debris with the presence of occasional inflammatory and foam cells. So if for a morphology like this, if you know that the patient had history of chronic pancreatitis, and if her amylase levels are also very high, then you can say that this is diagnostic, and it is diagnostic for a pseudocyst. So you can say your findings are compatible with a pseudocyst morphology. And if you are not able to say that this is a pseudocyst, if you are unaware of the amylase level and you do not know about the history of pancreatitis, then you can say that this cyst could. So now let us discuss the fluid aspirate from this 35-year-old female. And if we are getting a fluid aspirate like this, so in this aspirate we could see that there are abundant necrotic debris in the background. There is a dirty background and in which we could see some scattered foam cells and occasional inflammatory cells. So for a background like this, in which there is largely any paucity of the epithelial cells and which is showing you predominantly debris with occasional inflammatory infiltrate, then in this we will think of a pseudocyst, and this we are not going to call as non-diagnostic. So especially if the patient had a history of chronic pancreatitis and also if the amylase level are very high. So now for a morphology, suppose from the same cyst if we are getting something like this, so in this, as we could make out, there are abundant colloid like mucin flakes and there are hardly any epithelial cells, maybe one cluster here, in which we could see that there is some columnar like morphology. So for this lesion, this cystic lesion, we could make out that there is abundant colloid like mucin, but there is paucity of any papilloid or atypical fragments, and there are occasional tall columnar epithelial cells. So for this lesion, we are going to again categorize this as category 4, that is neoplastic, and then we are going to say that this is a mucinous cystic neoplasm, in which we can favor the possibility of mucinous cyst, and in which we can favor the possibility of mucinous cystic neoplasm or IPMN depending upon how the cell clusters are there within the mucin. So if we are finding papilloid clusters within the mucin flakes, then we will think of IPMN, whereas if we are finding tall columnar epithelial cells which are scanty in nature and predominantly mucinous material, then we are going to think of a mucinous neoplasm. Again, we are going to take the help of CEA and amylase level if it is known, and if they are not known, we will just say that this is a cystic mucinous neoplasm in which occasional benign columnar epithelial cells are evident. Now this is again another picture. If suppose we are getting a picture like this, again herein we could see that there is abundant mucin and there are largely no definite epithelial cell, but occasional macrophages are there. So again for this we are going to call it as a mucinous neoplasm, in which we are not able to differentiate it further. Now for suppose from this cystic lesion, if we are getting the abundant mucinous material in the background, and in addition we are also getting some papilloid fragments like this. Now these papilloid fragments are not the normal papilloid fragments as we could see here, as there is some nuclear hyperchromasia, there is overlapping of the nuclei. At places the membrane looks irregular, so these are definitely showing some atypical changes. So these are atypical papilloid fragments, and together with the mucinous material in the background, we are going to think in the lines of an IPMN, that is intraductal papillary mucinous neoplasm. So this again will fit into a category 4, that is neoplastic and IPMN type, and depending upon the grades of dysplasia, we can call it either low grade or a high grade dysplasia. Now from the lesion that we have described, if we are getting fragments like this, now as opposed to the mucinous background that was seen with the previous case in which the papilloid fragments was present, here again we could make out that there are many papilloid fragments as is seen here, but the background is not mucinous, rather the background here is showing you numerous bare nuclei which are similar appearing. So there are numerous small nuclei which are appearing monotonous, They are likened to each other, and many of them have got a round nuclei with finely vesicular chromatin. Now, in addition, these papilloid fragments, we could also make out that there is a capillary cluster around which these cells are arranged. So there is an endothelial fragment around which these similar looking cells are arranged. So if in the absence of mucinous background and the presence of these monotonous appearing cells together with papilloid fragments, this would fit in a feature of solid pseudopapillary neoplasm. And for this SPEN, in this we are going to ask the clinician to also make a cell block, because we can also do further IHCs on this lesion and confirm the presence of same. So an important differential of SPEN will be neuroendocrine tumors. As in neuroendocrine tumors, the cells again will be monotonous, but they will not show these definite papilloid fragments that are usually seen in SPEN. And in addition, you can get your immunomarkers done on the cell block, especially for the PR, CD10 and beta catenin, along with the neuroendocrine markers, which will be positive in SPEN. Now, so this is again neoplastic lesion, which is a solid pseudopapillary neoplasm. Then sometimes we could get an aspirate like this, in which there is a cluster of these cuboidal looking epithelial cells, and then in addition there are these scattered inflammatory cells, lymphocytes, some foam cells, and also presence of some foam cells with hemocitrin laden macrophages. So if these are laden with hemocitrin like material, then these are also conclusive for a serous cystic neoplasm. In a serous cystic neoplasm, finding of hemocitrin latent macrophages is relatively common. There is paucity of these cuboidal epithelial cells, as we could see here, and together with the foam cells present in the background, this is compatible with the benign cystic lesion, compatible with serous cystadenoma. So this is just a histology of the different type of cysts that are seen in the pancreas. So this is a mucinous cystic neoplasm, and these are defined by the presence of ovarian-like stroma and tall columnar mucinous epithelium lining the cyst. This ovarian stroma is classical for mucinous cystic neoplasm, and it will be estrogen receptor positive. Now we have already discussed IPMN, in which the tumor will be residing mainly within the duct. It will have a papilloid morphology like this, and this is a normal duct as opposed to this duct in which it is dilated and showing the numerous papilloid fragments. Now in solid pseudopapillary neoplasm, they are going to have a soft hemorrhagic cut surface, and as if they are going to come out from the lesion, and this is the surrounding normal pancreatic tissue. Now these lesions, they are called they will have pseudopapillae. The papillae are not going to show you the definite codes over here, and there will be presence of hyalinized material also within the cells, and this is the normal pancreas surrounding the SPEN. Now this is a serous cystic neoplasm, and in serous cystadenomas, they will have a large tumor. As already said, they will be occurring in elderly patient. At times they could have a central scar like it is beautifully seen here, and cut surface will be having a spongy appearance like that of a lung tissue. So there will be numerous small cysts which will be more beautifully highlighted on microscopy, wherein they will be lined by low cuboidal epithelium. And here you could make out that the normal pancreatic tissue is present at the periphery of the lesion. So this is a case of a serous cystadenoma, and it is just like that of a sponge. So it will have a spongy morphology. So with this we end the session here. Thank you so much, and we'll meet again for the next module.